Well, the diagnosis depends on gathering the history first, as I said before, and then examining the patient. And the challenge with tics is that often the doctor will see very little. In fact, the doctor may see no tics because one of the qualities of tics is that they are suppressible, meaning consciously or unconsciously, a patient can have no tics for transient periods of time. And often in the doctor's presence, under the scrutiny, the pressure of the doctor's appointment, the patient may show no tics. Our own strategy, and used by many colleagues, is to videotape patients. And we tend to put a patient in the video room and leave the room, let them relax, and then look at the video afterwards, and we can often see the blossoming of a series of tics. We also ask patients to bring a videotape from home so we can look at what we're talking about in the environment of the comfort of home. Once we see the repetitive movements in the distribution of head and neck, hear the noises, then we know what we're dealing with. Now, there are tics that can occur as part of other neurologic or medical conditions. Those are called secondary tics. But in fact, most children and adults who have tics will have Tourette syndrome. Tic disorders, by definition, begin during childhood. And we have followed patients, what we call longitudinally, over time. And during adolescence, that's the peak time of tic severity in most cases. And we don't know whether that is the natural cycling of the tic disorder or whether it's the challenges of adolescence and the stress of adolescence. But we see more tics typically in the beginning and mid-adolescence. And then, happily, most tics really decrease around the time of high school graduation and going to college. And there may be some peaks and troughs, but overall, the tics tend to decrease after adolescence, so that during adulthood, tics are quite minimal. I've had the experience of asking patients to come back and see me so that I could actually witness their tics. And most adults, when I've contacted them, they say, I don't have tics anymore. When they actually come in, they have tics. But they're very mild. They're very mild and of really low consequence. That's not to say that adult tics do not exist. There are cases, and these are often on the talk shows or shown on these various television series, but that is not the typical case. And I think that that's often frightening for patients with Tourette syndrome to see these cases and think that's where I'm going. That is not where they're going in terms of statistics. Well, it is a complex vocal tic, and there are other forms of complex vocal tics, which would be words that are socially acceptable. We are not sure exactly where these engrams in the brain are housed, but we think that elective language where we compose the sentence, is predominantly organized on the left side of the brain. Explicative language or spontaneous language, and swearing would come in that area, is more programmed on the right side of the brain, so that whatever neurologic activity is firing to cause these, depending on where it goes in the brain, we would hypothesize that would represent the type of tic. But these are theories. We don't have this really worked out at the present time. The main and important thing of treatment is to educate patients on the expectations. I do not treat tics if patients are well adjusted to their tics, because I don't want to deal with medication side effects. And I consider that every child has 3 jobs. He has to go to school and get good grades, because that's the ticket for success. He has to go to school and make friends, because he has to be able to work with other people as an adult. And learning those techniques is pivotal to success. And the child has to be a good citizen at home. So when the parents ask him to do things, he has to comply. He has to be a good citizen. If the tics interfere with those, then I'm motivated to go into medication treatment. But if not, then I just observe and continue with the educational program. Now, if there are problems with any of those, even before going to medicine, often good psychological counseling and learning techniques of behavioral modification may solve the problem. Special arrangements at school to allow a child to sit in the front of the classroom to maintain his attention. Sometimes bringing in educational forces into the classroom to educate the other students and the teachers about the tics, that they're not contagious and they're not dangerous, and to be understanding. That often diffuses the whole problem. So all these are non-pharmacologic means. Well, the side effects, of course, depend on which medication, but the typical side effects are sleepiness, and in the potent medications, we have a great deal of problems with weight gain. And this is particularly problematic in my view because a child already may be teased because of his tics. And then you make him fat and you just displace the ridicule. And this is a real problem. There are other side effects as well that can be problematic, and one of the most important for the high potency, what we call neuroleptics or antipsychotic medications, is a syndrome called tardive dyskinesia. It's not common, but it can be induced by chronic exposure to the medicines that we are prescribing for the tics. And this tardive dyskinesia is another movement disorder. But the risk here is that we're trying to treat one disorder and we are putting a child at risk for another disorder. And that's very concerning to the doctor. And it should properly be concerning to the patient and family. So we, again, emphasize how important it is to judiciously use the medicines, and if we can, to use them at the very lowest doses and for as short a period of time as possible. Well, Tourette syndrome is very much an underdiagnosed condition. But I don't know that it needs to be diagnosed if a patient is doing well. I have 3 children, and as a parent, I was always welcome to come and visit the child's classroom. And I never missed at any of my parent conferences to witness children in the classroom with tics. They're very common. But there'd be little use to bring attention to it unless it's causing some kind of concern to the patient, the family, or the teacher. So it is underdiagnosed, but I don't know that overdiagnosing it moves us really forward in terms of concerns. I think projects like this, where you're emphasizing the more mild patient and the more typical patient, allows that if it's diagnosed, that families and patients can go to informational sources and understand that, oh, well, I wish I didn't have it, but I still can rally. I still can have my full career. I can still raise my own family. I don't have to look at these exotic cases that are on the talk shows and think that's where I'm headed, because that's not where the typical case is headed. Well, a big area of research is a genetic study to try and find out how this is transmitted from generation to generation. We are quite convinced that for most patients with tics, this runs in the family and that it's passed generation to generation. The trick here is that tics are not a static condition, and they're difficult to witness when the doctor walks into the office and sees the patient. And genetic studies depend on labeling a patient, yes, Tourette syndrome, no Tourette syndrome, and then drawing the blood and trying to construct a family tree. If you don't see any tics, that doesn't mean you don't have Tourette syndrome. And the trouble is, if that blood is drawn and the patient is labeled no tics, but he really has tics, you've ruined your data. And that's a problem. So the studies of genetics, while they're a great focus, they have been very slow for us to make progress. But that is a big area of current research. Another area of research is focusing on the anatomy of this disorder. And we have a new technique that is called functional magnetic resonance imaging. And standard scans of the brain look at the anatomy, but they don't give us any idea about function. But the functional MR technology allows us to look at what's going on in terms of activity of the brain and trying to capture these tics, that we could actually see what area of the brain is working or not working when a tic emerges is a big area of research. And we hope to establish in a given patient where these various behaviors are emanating. And this technique has a great possibility for our moving the science ahead. And then the third area is, of course, developing better treatments. And this is so important because we have growing children, we have teenagers, and we want them to be effectively treated, but we don't want to deal with side effects. And so working on this has been another area of real top priority.